Please join me in warmly welcoming Dr. Pranay Hajare. Dr. Pranay, over to you.
Thank you, Vishaka, for the warm welcome. So, good evening, everyone. I'm Dr. Pranay Hajare. Today, we are going to discuss how we can move from the subjective observation to objective measurement with the help of center pressure as a clinical mark. So, as a physiotherapist, we are trained to observe the gait, but observation alone has a limitations. Two therapists may interpret the same child gait differently. Parents often ask how we can improve, how we can know it's improving. So video recording are helpful, but if they don't provide the numbers, and without the numbers, the progress becomes very subjective. So let's start the journey to explore the pediatric gait. Is my screen is visible to you all?
Yes.
Yeah. So pediatric gait evaluation. So in pediatric gait, the critical for the four major reasons. So early detection, which is the subtle deviation from the structure deformity. Next thing is prevention, which reduces the long-term joint overload. Third thing is the objective of monitoring. So objective monitoring in which there will be a tracking of the neuromotor development. And next thing is your treatment plan. So in treatment planning, there will be the guided physiotherapy and orthotic decision will matter in the treatment plan. And the earlier we detect the immaturity, the better we intervene. So to let's understand more about the pediatric gait evaluation with the help of COP. So before going further, first we need to understand what is a COP. COP is the center of pressure, the point where the average location of the force being applied to the ground by an individual. So normally when you walk, when you do the heel strike, the COP will be starting from your posterolateral side of the heel. Then when you move further in a mid stance, it move anterior to the mid foot. Then on a terminal stance, it will go to the medial of the forefoot region. And during the toe of position, it will go to the greater toe at the hallux region. So it is nothing but it will make a smooth S-shaped progression on your foot when you do the walking. So this is symmetrical between both the limbs. This progression reflects how the effective loading is transferred through the foot. So here is like why center of pressure is crucial in children. So unlike adults, children have developing motor control, immature posture stability. They have a wider base and variable time. In COP progression is direct. What it directly reflects is your neuromotor maturity. So here it comes the major rule. A smooth heel to toe COP path shows the well-developed motor control. If there is an irregular or zigzag or developed forward progression, suggest an immature or impaired motor plan, which is most common in cerebral palsy and developmental delay patients. In children, the COP becomes the more linear as the central nervous system matures, which indicate the smoother the center of pressure is, the better the CNS integration will be. So next thing is balance strategy. So balance strategies will tell you how the COP movement shows how the body maintains the stability. The axis, the mediolateral deviation, indicates the poor posture control or compensation. Stable COP with minimal sway will be the effective balance control. The excessive COP deviation will result in compensatory balance strategy. So the person who is having the excessive center of pressure deviation in his foot, that will represent the person is having that child is having compensatory balance issue, which because of which the person that COP is getting deviated mediolaterally or anteroposteriorly. Next thing is load transfer efficiency. The center of pressure tracks how the body weight moves from heel to midfoot, from midfoot to forefoot, and from forefoot to toe off. This interrupted delayed or progression indicate the weak push-off, or sometimes it can be due to some poor ankle control, abnormal loading patterns. So this can be the causative factor for load whenever there is COP tracking to identify the load transfer efficiency. The smoother the forward center of pressure, the effective the energy transfer during the gait. So instead of guessing maturity, we can measure it. So how the normal center of pressure progression across the gait development. So in typically the children's, as the age increases, the center of pressure also increases. The center of pressure velocity becomes more smoother, and the variability decreases. As a result, medial lateral deviation also reduces, in which the heel to toe continuity improves as the maturity equals to the smoother COP. The larger the COP progression, the better the maturity is there. So what happens if there is a developmental gait delays? So now let's understand how the key abnormalities are common seen in the pediatric and the neurogate analysis first. The shorter the center of pressure. Here, the COP does not travel from the heel to toe distance. This is often indicated with the push off, forefoot underloading, or maybe due to some limited ankle mobility. Okay. So next point is fragmented or discontinuous COP. So what will happen? So instead of getting a smooth curve, we see a break or irregular jumps of the center of pressure marking. This suggests there are the poor motor control instead of inconsistent weight transfer. So next point is increased mediolateral center of pressure deviation. Whenever there will be the excessive side-to-side movement reflects the balance defect, which is compensatory strategy due to some weak trunk or due to some ankle control. So next point is reduce the center of pressure velocity. So slow the advancement of the center pressure, which indicates that there is a cautious gait, hypertonia, weakness, or reduced confidence during the walking. This subtle center pressure changes help us to detect if there is any functional impairment even before they become a visually obvious. Okay, so these are the main four gait abnormalities which will you will see if there is a developmental gait delay, which can you can measure with the COP. So why the center of pressure progression is superior to the visual gait analysis? Let's compare the traditional visual analysis with the center of pressure analysis. Visual gait analysis is subjective. It heavily depends upon the children's experience and interpretation, clinician's experience and interpretation. When the center of pressure analysis, on the other hand, is an objective, it converts the movement into measurable and a reproducible number. Okay. On the other hand, the visual assessment may miss some subtle delays, sometimes, especially in the early motor immaturity. But the center of pressure detects this early detection with the quantifiable parameters like a path length, deviation, and velocity. And the most importantly, the center of pressure allows the longitudinal monitoring. So we can track the progress over a week, over a month, and the treatment phases with a real data, not just on basis of your observation. So that's how we shift from experience-based assessment to a true evidence-based practice in a pediatric gait analysis. So what are the clinical indications where the center of pressure monitoring is mostly valuable? So when you talk about the pediatric gait assessment, children don't show the obvious abnormality when they walk, when they run, but sometimes something feels slightly off, right? So these are where the center of pressure monitoring becomes extremely powerful. In children with a developmental coordination disorder, we often see the irregular inconsistency of the center of pressure progression, which reflects the poor motor control. On the other hand, in the mild global developmental delay or a late walkers, there's a common factor the COP path may appear immature or unstable, showing a delayed neuromotor development. Okay. Uh, Next, we go for on a hypertonic children, where the center of pressure clearly reveals there is an excessive sway or a medial lateral deviation. Sometimes may be some obvious during the simple observations too. Next thing, if after the immobilization also, as you mostly notice, the center of pressure helps you to detect the asymmetrical loading or sometimes or a fear of avoidance pattern in the children. And in the preschool children with a frequent fall, there is subtle delay in a forward progression or a poor push-off becomes measurable. So these are the cases where the subtle data truly makes a big difference because the center of pressure analysis itself allows you to see what the eyes alone cannot see. So one thing, the one most common questions will comes in mind is the center of pressure is more accurate, is it reliable in children or not? So center of pressure is a valid biomechanical parameter supported by a strong research evidence. It demonstrates high intercession reliability with the multiple trials are performed when the data is consistent and reproducible. In children who can walk independently, typically mostly above 3 to 4 years of age, the center of pressure provide a reliable and a clinical meaning insight. However, it is not replacement of a clinical examination. So it is a complementary tool that enhances what we observe. We combine with the clinical reasoning and the muscle assessment and the functional analysis with the center of pressure strengthen our diagnostic accuracy. So with the help of plantar pressure system, we avoid we move beyond subjective observation. We shift towards the objective measurement and reinforce the true evidence-based pediatric rehabilitation. So before going that, we need to understand the plantar pressure system. So how the plantar pressure system measures the center of pressure? Plantar pressure system works by capturing the time phase pressure value from hundreds of sensors embedded in the platform. In that platform, we tell the patient or the child to walk, uh, after which each sensor record how much force is applied at a specific moment during the stance and the gait. Using these pressure values, the system calculates the center of pressure as a weighted average of all active centers. In the simple terms, tell us where the body load is concentrated in every millisecond. From this, we get a measurable parameter in which the center of pressure metric is used. Center of pressure path. Center of pressure can be measured in the four major metrics. Center of path length, which shows how far the pressure travels during the stance. Next thing is center of pressure exertion percentage, which tells you how effectively the weight moves from heel to toe. Next thing is center of pressure velocity, which indicates how fast the load transfer. And last but not the least, medial lateral deviation, which reflects the balance control and side to side stability. So essentially, this parameters converts the movement into objective and measurable number, transforming the observation into a quantifiable data. Okay. So clear COP visualization. The OM software presents the center pressure data in a clinical meaningful and visually clear format. It shows you how this heel to toe COP trajectory allows you to understand how the weight progress during the stance and during the gait phase. So this highlights the mediolateral deviation, help us to identify if there is any balance instability or the compensatory patterns is there or not. And it also enables you to do the side to side comparison, which is especially valuable in asymmetrical conditions. So the real clinical advantage in this is to transform your biomechanics into something visually understandable. This become extremely useful for the parent counseling.
27
It's become
participants.
hello, yeah. So this become extremely useful for the parent counseling because the parents can see the problem, but not just hear about it. So yeah, it also support the interdisciplinary discussion with the pediatricians, with the orthotists, with the neurologists, and it's an and most importantly, it strengthens the documentation with the objective visual evidence. So let's have a look on this case study of the 12-year-old male patient whose chief complaint was pain and discomfort in the feet after an activity. So, what are the clinical findings we got in this? There was a gradual onset of pain and discomfort while doing an activity. No significant history of any injury. So, on a physical assessment, we got to know that there is a bilateral navicular drop, which is positive, and increase on first metatarsal and forefoot loading, and also the calcaneus was in eversion position. Next thing was the subtalar joint pronation is for finding founded out. Next thing is tibial internal rotation was positive. The patient was having a genuine valgum and the right knee hyperextension. So the diagnosis was the flat foot with bilateral overpronation, in which we started with the treatment of foot eccentric strengthening, calf stretching, proprioception training, like a single leg stance, and the insole modification for restoration of the deformity. So how we document it? So let's have a look on the documentation part. So this is the bipedal stances, which is the static stance. So this assessment will show you how the overall weight bearing of the left foot was. Where, however, within the right foot, as you can see, there is an increased loading, specifically in the hindfoot region, suggesting the posterior dominance or altered load transfer. The foot impression patterns appears now abnormal, indicating the possible biomechanical imbalance. So, interestingly, there is a maximum pressure values remaining within the normal range. So, the maximum pressure, ideally, whenever the person stands, and the maximum pressure on the foot should be below the 130 kilopascals of the pressure, meaning there is excessive focal overload is not present in this case. So this case reflects altered distribution rather than high pressure pathology. Okay. So next test we perform the dynamic test, which is the walking test. We tell the patient to walk on the platform, and after that we get a report of the dynamic test. So in this we will see the center of pressure line trajectory on this. So we can see the center of pressure trajectory is not much prominent over here. It is not starting from the head itself. It's starting from the some mid zone of the rear foot itself. So next thing is the main finding which we get from this dynamic test is your arch index. So arch index nothing but it will tell you how the foot is in whenever the person is walking, how the foot arch was there. Like is it was a flat foot, is it was a high arch foot, or is it normal? So we will calculate the arch index by what all the pressure on the foot is there. It is divided with the midfoot zone. So how much the midfoot will get contact with the plantar fascia system. So that ratio will be calculated. So mostly the normally the ratio should be from 0.21 to 0.26. If the ratio is crossing more than 0.26, it indicates the person is having a flat foot condition. So as you can see, when the arch index in the report itself tells the left foot is having the 0.37 and the right foot is having 0.36. So both feet shows increased higher arch index value, suggests the reduced medial longitudinal arch, which indicates that their person is having a flat foot condition. Correct. So on the right foot, right foot had a significant high peak pressure, as you can notice the peak pressure. So peak pressure is nothing but what was the highest pressure, what was the point where the highest pressure was there, and how much kilopascals of pressure was there on the foot. This will be noted in the peak pressure values. So in this report, it suggested the right foot had a significant higher peak pressure, indicating there can be a hello. So if you guys have any doubts or something, you can have a text on the chat box itself. After the completion, after the end of the session, we will take all your queries. Right? Okay. So this increase in a peak pressure can cause the localized tissue risk, like high pressure on the tissue, which can damage the tissue on the particular side of the foot. So next thing, if we go on the center pressure exertion index. So over here, the center of pressure and exertion index. First, we need to understand what is the center of pressure exertion index. So it measures the concavity of the center of pressure curve during the gait. It reflects amount of pronation or supination of the forefoot whenever you're walking. So it is calculated with the percentage of exertion of the center of pressure with the construction line connecting from the first and the last point of the COP curve. So measuring the by measuring the forefoot width. So what the normative of this value is 13.9 to 26.9. So over here, as the value is in the normal range, so that indicates the person is having or not the forefoot is not going much in pronation. Okay. So next thing is stability test. So stability test. This is the assessment for a balance. With this balance was tested in a narrow base of position. So we'll tell the patient to perform the same test in a narrow base of support in an eye closed, then first in eye open, then in an eye closed position. So in eye open, when the with the narrow base, the sway remains controlled with a visual, vestibular, and proprioception system, where all the three parameters will contribute for the stability of the person, right? So when we close our eyes, we reduce visual input is removed. So the child must rely more over the proprioception and the vestibular system. So normally the sway increase slightly under this condition because the base of support is narrow. Approximately there will as the base of support is narrow, there is approximate 2 to 4 centimeter gap in between the feet. Medial lateral sway naturally increase due to this reduced stability margins. The eye closed is a narrow base because most sensitive condition detects subtle sensory integration defect. So excessive sway suggests more proprioception vestibular deficiency or dysfunction. So posture distance, sorry, the sway distance measured in a millimeter represents the total movement of the center of pressure during standing. So for as you can see over here, the sway distance is normative is under the normal value, which suggests that there is a no risk of fall. So how we get to know that is the it is a normal value? So normatively, the eyes closed sway value should not cross or exceed the 50% value of your eye open value. Okay. So whenever the value is more than 50% of your eye closed position's sway distance value, so that indicates the person is more dependent on your visual clues. So which for whi- from which we find out the person is more dependent on his proprioception and vestibular function. Okay. So in this case, the sway ratio is within a normal limit, indicating no risk of fall. However, the center of pressure area is more focused on the left foot. So that we can get to know in this image itself. The center of pressure is more concentrated on left foot, suggesting there can be the habitual loading or symmetry rather than a sensory defect also. That can also be the causes. So we are not just measuring the balance, we are just assessing the sensory control and the postural strategy of the person whenever he is performing the stability test. Okay. So next thing, as we discuss in the treatment also, we perform the single leg stance for the 10 minutes. So in the single leg stance, as you can see over here, the left foot center of pressure is more concentrated on a posterolateral direction, which indicate that there is a hindfoot dominance over here. So that can be due to the calf tightness, as we get to know that there is a calf tightness present over there. Next thing is on a right foot, center of pressure concentrated near the medial midfoot region, near the arch. So this can be subtle asymmetry is difficult to detect visually, as you can if you saw the images of the person itself. So by seeing itself, it's not that much prominent that this can be the center of pressure can changes in both the feet. So this can be the pressure distribution between the both the feet when you perform the single leg stance. So this all the objective data we will get in the plantar pressure system when you do an object assessment over here. So in treatment, we initiated the foot eccentric strengthening, calf stretching, and a proprioception training. Also, we added the insole modification. which providing the R support to the child, and he can use in his daily day-to-day activities, like so you can use in his for sports shoes itself. The treatment was guided by an objective data which we got from the report itself. It was not an assumption or it nothing like this will work or not. It is purely based on what all the reports we get on the test itself. So this is the clinical application theory. So as I told you, the center of pressure, before it was very like short COP was there. It was not starting with the heel itself, and there was some zigzag transition. As you can see, the black line over here. This is not just a line. It a center of pressure was there on particular point whenever the person was walking. Like it started from the heel when heel strike, then midfoot, forefoot, and then toe. So that how wherever the location of the CPO was there, it was plotted there, and that plotted line is the center pressure trajectory over this. So more the zigzag line indicate that there is a most time duration. The COP was there for more time, and that's why the zigzag this appear more like a zigzag pattern. And it also, where the darker the broader the line will be, it indicates there is a slow progression of the central pressure over there. Okay. After the treatment over the 5 months, and so took the test again. So which indicate the increased central pressure length, which was not that much prominent, but before, as we can compare it the before image, so we find out it the COP length was much prominent. The smoother the heel to toe transition is much smoother. It is not a broader gait line. It is like the thin line over there, and also the reduced medial lateral sway. Because of medial lateral sway, we will get that zigzag line. So when we as a person as a child gait matures, that COP trajectory also matures. So that time we will get a smoother heel to toe transition. Okay. So now the progress is measurable. It is not just observable. So that all things you can judge with the center of pressure in a objective manner. So here we comes for the therapist point of view. So there is some silent problems in a pediatric rehabilitation. As a therapist, we often struggle during reassessment. We work hard, we see the small improvements, we feel the progress, but the parents ask, how do we know it's improved? And that's where it's become difficult because without objective numbers, our clinical expertise can feel invisible. We rely more on observation, experience, and intuitions, but families often need some measurable proofs. This gap between the clinical knowledge and the measurable evidence is exactly where the objective tools like COP analysis makes a difference. So, why this matter for your practice? This is where the structures center pressure analysis transform your practice. It converts your routine gait assessment into a structured, billable clinical service, not just an observation, but a measurable evaluation. By adding a objective reporting, we strengthen our perceived clinical expertise. We are not longer just explaining the progress, we are demonstrating it with data. When the parents see measurable improvement, changes in the center of path, symmetry, center of pressure velocity, their confidence increases, your confidence increases. When the confidence increases, the complaints improve. Ultimately, this supports the premium positioning of your clinic or a rehab setup because you are not offering just a therapy. You're offering the evidence-based practice, a data-driven pediatric care. So, how the ohm plantar pressure system supports the revenue growth? So, center pressure analysis helps to create a dedicated gait analysis packages during the routine assessment into a structure service. It strengthens your orthotic and insert prescription by providing your objective justification. It improves the assessment to the treatment conversation because the families clearly understand the need. And through the measurable progress tracking, it's naturally encourage the follow-ups. So it's not just a clinical data, it is a smarter structure and evidence-based practice. So there are the takeaways, the key takeaways of this session is home plantar pressure system enables the early, objective, and reliable identification of center of pressure in a developing gait delays of the children by accurately monitoring the center of pressure during walking. So center of pressure do not rely on the clinical reasoning. It supports the faster, cleaner, and more confident decision. The home plantar pressure system enables that. Thank you so much for attending this webinar. Is there any questions? Let put in the chat box. We will have the Q&A session now.
Dr. Pranay, we have one question. We have question from Dr. Sudhanshu Kumar. He is asking for normal value of arch index.
Yeah. So the normal value for the arch index is 0.21 to 0.25, 0.21 to 0.25. So if the value is increasing more than 0.25, so that indicates the person that midfoot arch collapse is more. The midfoot is getting more contact with plantar pressure system, which suggests the middle longitudinal arch is more getting involved. So that indicates the pes planus condition, and vice versa for the pes cavus condition.
Thank you, sir.
There is one more question. Where we can take this training from Dr. Zahir.
So training about the center of pressure you are asking about, or like you're training talking about the plantar pressure system?
Till that time, we have another question. Hi, sir. Can we do this gait parameters in normal school children?
Yeah, you can perform in normal school children also, because mostly the school children's having you can also check this parameters in the school going children with a heavy bag also, because of you can see the what all the changes is there because of that heavy load of the bags. And you can track because mostly they are developing child, because their arch is also developing. So if there is any flat foot condition, or the child is needed that treatment, early intervention is needed, so you can definitely go for the school children.
Okay,
Sir, I had a
there is.
question. Sorry to interrupt, sir. Sir, can I raise a question, sir?
Yeah, sure.
Sir, for RCT to test effectiveness, as you said, it is an evidence-based practice you can use. For randomization is possible in these type of studies.
Yes, ma'am. Randomization is possible, but criteria is the child should be more than 3 to 4 years of age.
As in pediatric neuro rehabs, quasi-experimental studies is mostly accepted, and there is a lot of ethical concern. And what about your opinion regarding this, sir?
So ethical consent will be depending on the what are the setup you are using also. So the assessment should be prior informed to the parents also, because their consent is also matters. So you have to explain why you are performing this test and what's the outcome of this test,
Sir,
how this.
as you say, no, before take away message, as you said, whatever you're doing is visible to the patient, and the patient mother is asking questions. So blinding is not possible in these type of studies. So randomization is possible or not possible? I'm asking in that way. Could you get it, sir?
So you're talking about random control trial, right?
Yes, sir.
So randomization is possible, but that's what I'm trying to tell. You can't randomly take the different childs. It should be more than 3 to 4 years of age. And next thing is like you should be having the proper uh, randomization in the sense I'm telling about the age criteria, not
Oh.
just based on the gender and not based on the condition I'm talking about.
For testing and effectiveness of intervention, you can take it as a observational tool, sir. Not all the parameters what you said. You can take any or 2 or 3 parameters and we'll put documentation like that, sir.
Yes, you can definitely do the documentation of this, because in the report itself you will find that measurable value. So you can do this documentation and you can perform the test also.
As you talked about more parameters, can we take everything is mandatory to do documentation, or for any one of the tool you can use and do a documentation? I'm asking like
So it
that.
depends on like what study you are performing. So everything you can document. You can document the center of pressure exertion index. You can document the center of COP path, the sway distance, and sway velocity. These are the primary factors in the children's itself. But you can also include the other parameters, like as I mentioned, the arch index, the peak pressure values. That also you can include in your study also. That's not an issue.
Sir, in your study, you're taking the children's for your study, no, sir? For that, cognitive impairment is very good, no?
Yeah,
The child
but
can able to understand what you are telling and what you are saying, no? It should be very cooperative, and it should follow your comments, no? That children's you are
yes,
going to
ma'am. That's a primary thing we have, because we are telling that we have to whenever we tell the patient to walk on the platform, so we have to follow the SOP. That time we don't have to look on the plantar pressure system. We have to look straight forward. That understanding, that cognition should be, if the patient or the child is having that much cognition, you can perform that. But if a person, that child is not able to perform the step because of cognitive impairment, I will suggest don't go for the cognitive impaired patient, because they won't follow the SOP, right?
Yes, yes. And cost effectiveness of your intervention, sir. This you're using this type of, no? Can you tell roughly cost effectiveness? No, is it affordable to everyone?
So what I told about the cost effectiveness, so you can add it in your routine assessment. If you find the particular child is having their cognition is intact. Next thing is like if you find there is some something like we are overlooking, like we are in assessment is not giving that objective data. So you can add it in your routine assessment also. Whenever the child comes to your clinic, whenever the child comes to you for the assessment purpose, you can have this we can explain the parents. So we will perform this all test, and we will get a documentation how the your arch of child's arch is there, where the peak pressure is there, on which region the pressure is getting high. So what can be the there can be early preventions too if there is an abnormality present over here, so which we can prevent getting worsen in the future conditions. So that how you can explain the parents itself, and you can show the before reports also, for like how you can how will we documented it. And also whenever the child comes to you for the therapy also, that time also you can perform it like as a custom test, as told you. So single leg stands and other like exercises also you can perform on the plantar pressure system. So that time when you perform it, you can also document that progress also, and you can show it like we are just not telling that your child is progressing, we are also objectively giving you that report itself, that yes, that the child is improving, and we have some proof we can show you. So it's not a blind trust the parents are putting. It's some objective data also you're putting to the parents, that will show you which you can charge itself. That's all your reports which you are generating with the plantar pressure system. You can charge it separately as an assessment tool.
Does it need practice for a therapist to take this study, sir? This test and all,
So
what you're telling,
yeah,
explaining all these
practice
things.
in the sense you have to go through again and again. In the sense, when you initially when you interpret the report, you will find little bit difficulty. But as you started explaining the reports, as you started understanding the food more about it, it's very easy to you. It's not there is nothing very complicated theory over this. Once you start using the plantar pressure system, once you start reading the reports, and you start correlating your clinical findings with the plantar pressure report, that time you can explain it more widely, and you can understand more. There is no specific other training you need about it. Once you know about your assessment, once you're firm about your assessment, once you know what the report is telling to me, that time you will get a more clinical idea about it, and you will be more confident about it, how you can explain to the parents itself.
Thank you, sir.
Okay, ma'am. Do we have any questions more?
Yes, we have another question from Dr. Roshni. How we can assess for the case who is adapting to walk with foot toes closed from childhood.
So in this case, the adaptation of the walk with the foot is closed from the childhood, right? So that time the person you have to see the center of pressure of the center of pressure. As I told you, whenever you first you have to check in the standing position where the center of pressure is like where the high pressure zones are there. Mostly in the toe walking, like foot, there will be the high pressure on the metatarsal and first hallux region. So that time you have to notice where is there any maximum pressure present on that. As I told you, the maximum pressure on the in a bipedal stand, in the static stand, it shouldn't cross more than 130 kilopascal. If there is a high maximum pressure zones on the forefoot region, so that time there can be chances of some tissue damage, or it can leads to some other complication in future also. So that thing you have to prevent first of all. And next thing is whenever you perform the dynamic test, that time you will find the center of pressure is more on the anterior side of the foot. As you saw the COP line, as I told you, the COP trajectory will be there. So it will, whenever you see the trajectory on the that forefoot region and the hallux and toes region, you will see the trajectory is more shifted on the medial side. Ideally, it should cross with from the hallux region, right? But it won't cross with the hallux region because the toe of is like toe of is not that much prominent. And you can see the heel region also when the center of pressure start with the heel region, it won't be starting with the heel tip of the posterolateral part of the heel. It will start somewhere between the foot, between the midfoot and the rear foot region. So that all the changes you can see in the person that child is walking the toe foot tiptoe walking or foot with the toe closed position. Also, one more thing you can see, which I didn't mention in the report, but you can see the foot progression angle also when the person is walking. So in the foot progression angle, so we will see the how much the toe in and toe out the person is walking. So there is some normative value for that also. So it's from -5 to +20 degrees. So if it's the foot progression angle is more than -5, which is so it indicates the toe out position. And if the foot progression angle is more than 20 degrees, so it indicates that the person is walking more in toe in position. Okay.
So biofeedback and this have any similarities?
Yes, ma'am. So biofeedback, we will so this all test we perform in the we are not giving any biofeedback in the all three tests, but which I showed you the single leg stance, right? So you can show it to the person who is performing the test also. You can show the child itself when we told him to do the single leg stance. That time you can tell the child to perform an exercise. So what all the movements he will do, what all the sway he will do, so that all you can see on the screen itself. So that can be the visual clues or the biofeedback for the patient. So for you can use this as I mentioned for the single leg stance. You can use it for other purposes also. Whenever you're performing for eccentric muscle strengthening, you are trailing to toe curls on the plantar pressure system. You can show it to the show the screen to the child itself how the pressure is changing on the foot itself. Next thing you can tell to perform some lunges, or you can tell to perform to do some squats also. So that time how the center of pressure is moving, how the pressure distribution is moving. So that all things also you can show the visual feedback, so by feedback to the patient itself. So he also get to know how my like body position is matching, how my whenever I change my body position, how my foot pressure is differing. So that all things also makes him interesting. He also gets some curiosity how my body is working on my foot also.
Sir, how is the acceptance level of the parents when you talk about and when you give justification, we are going to do these sort of studies for your children's home? Are they accepting, or still there is a clinical scenario less acceptance level in case of pediatrics?
Acceptance is depends on the like how you interpret this. For example, if the child comes to you, and what makes you difference with the other therapist? So other therapists are doing the same thing. They are also documenting this the same way. What they are also doing the same treatment. What's making you different from others? So that way we are pitching it to it. We have the plantar fascia system. We are giving the we are documenting everything in a numerative values. We are documenting the progress of the patient. We are documenting how the whenever the therapy sessions were going on, that time also how the patient is doing, how the progress, how the pressure distribution changes when you perform any particular exercise. So that all things when the parents get to know that yes, because after doing this exercise, after doing this thing, my child is improving, and I can see that with the some months of transition, we can document it and we can show it from day one itself to after the particular days or particular months, how was the improvement was there. So that all things parents also appreciate, because at the end, because every child's parents need their child to be get cured, so they want some trust, they want some that faith that my child is improved. So that needs, for that gaining that faith itself, we need some evidence. So this reports also can help you to give some evidence, and your clinical practice and your clinical knowledge makes it more confident to you that yes, what I'm doing now, it's the right thing and it's right for your child also. Okay, ma'am.
Thank you, sir.
Welcome, ma'am.
Dr. Pranay, there are no other questions.
So thank you everyone to who joined this webinar. It's literally very appreciating you to spare your busy schedule and attend in this webinar and making it successful. Thank you so much, all the physiotherapists and clinicians who all joined over here. Thank you.
Thank you, Dr. Pranay. So everyone, thank you so much